So ladies and gentlemen, let me say something here. The first time you're having a team from San Francisco. So this time, the team from San Francisco, let's hear it for them, the Frisco Flomaxinators, headed by David Chang.
Hooray! Arnold Schwarzenegger.
Two eye surgeons from the San Francisco area discovered that Flomax can cause complications during cataract surgery. When I heard about this, I realized that we need a Terminator to solve this problem. And so I asked one of them, Dr. David Chang, to assemble a special governor's task force, the Flomaxinators, to terminate these iris problems. I am counting on them to be able to say, hasta la vista, baby, to floppy iris complications.
Well, we are the Flomaxinators. I've flown 3 people out here with me from San Francisco. We've got Dr. Mandeep Randa, Dr. Abe Vasavada, Dr. Gaurav Luthra. All right, well, let me go ahead and show my first video, and then we'll follow with the others. So we're going to show a complication first of a traumatic cataract. And you've seen a couple of them. So let's see how this one goes. Now you see the large defect temporally, or on the nasal side. Media unavailable. All right, and that concludes my presentation. So we're going to go, oh, we've got it. All right. So the first thing we're going to do is put a dispersive viscoelastic to wall off that area, and then I need to support that large zonular defect. Turns out that iris retractors are really good for this because the conventional capsule retractors would be too large. Now, one of the best ways to go about this is to use a bimanual INA. You see, I continually go back and cover that area up with viscoelastic. Bimanual INA, I can keep the irrigation much higher so it won't go through the zonular defect, hydrating the vitreous. And now I'm going to decide what to do. I've got to certainly put in a CTR, and then we'll see about how I'm going to fixate the lens. I do this very carefully, and what I want you to watch is when I put the CTR in and I remove the hooks, look at how the CTR expands the bag, redistributing the force. But the problem is when I try to put the lens in the bag, the whole capsule swings backward like a barn gate, and I've got to stop. So I said, what do I do now? I can't put it in the bag. I put it in the sulcus because I have this 3-piece lens. So I will put this in the sulcus and then see if I can maybe just capture the optic with the rexus using the ciliary body to support the 2 haptics. So far, so good. And then I'm going to just take out the viscoelastic, put in some Myocol, and go home. Now, what I want you to watch is when I take out my viscoelastic, so here I'm sort of capturing, button-holding the optic. Look at the CTR and see if you notice anything. So I'm taking out the viscoelastic, and I'm bothered by that little clear space that's appearing peripheral to the CTR. And I'm thinking now, why is that there? So I hope to get the pupil down with Myocol. I'm going to put that in. And what do you think? Can we go home is the question, right? The CTR is in a different position. The pupil didn't come down, so I need some advice. Now, in San Francisco, we have a police department, a very famous inspector, Inspector Harry Callahan, okay? You may have seen him in the movies as Dirty Harry, and we have the sound up for this part. So let's ask him.
I know what you're thinking, Dr. Chang. Is there vitreous? Well, you have to ask yourself one question. Do you feel lucky? Well, do you?
All right. Well, we have another person to ask. Senator Rand Paul's an ophthalmologist. He's the leading Republican candidate for president.
Well, Dr. Chang, if I was a Democrat, I think we just inject some iocone, cover it up with a patch, and go on home. But being a Republican, I think we ought to look for a solution. We ought to see if there's vitreous. We ought to inject some triamcinolone and get rid of the problem.
All right, so Senator Paul, he's an ophthalmologist. Let's do what he said. I'm going to inject some triamcinolone, and look what happens. Here I thought I had done such a nice job. Imagine this much vitreous coming through there, and now I've got to address that. So how do we get it? This is the time you really want to go through the pars plana, because if you were to aspirate this from the limbus, it just keeps coming from behind more and more forward. Instead, I'm going to go 3.5 millimeters back. This is a disposable MVR blade. Now, I've got an infusion cannula that I'm going to fixate at the limbus on the right, and you can see the vitrector here, and watch how, because I'm behind the IOL, the vitreous is actually pulled from the anterior chamber into the posterior chamber, thereby cleaning it up. And so that's really the key. This is the time you want to use a posterior segment approach. Thank you. Next up, Dr. Mandeep Lambda.
I'm going to just reinforce what Dr. Haldipurkar was saying and show you how to record videos for OPL. I'm going to teach you how to make simple cases complicated. I had this patient who came to me 2 weeks back. This was a case of pseudophakic bullous keratopathy secondary to a AC IOL. Plan was very simple. I thought I'll just remove the IOL, explant it, do a gluteal implantation, and then my cornea colleague will come and do a pre-dispense endothelial keratoplasty. The moment we entered into the eye, things started getting a little murkier. I soon realized this is not a free AC IOL, it's actually an IOL tucked into the iris. So little change in the plans. I used a cornel scissor to cut the optic-haptic junction and thought I'll just remove the optic and leave the haptics behind. Right then, two things started getting terribly wrong. First thing, the moment I was trying to explant the optic, it flipped, slipped, and down she went. Second thing, right when I was trying to suture the port, unwanted guest appeared into my anterior chamber. Out of nowhere. A grade 3 nuclear sclerosis. He was like, just take me out, man, I'm here for such a long time. It was like Sanjay Dutt waiting for his next parole date. So used a wire vectors to remove this nucleus out. Went ahead with, I secured the corneal wound and did what I do the best, 3-port pars plana vitrectomy, did a PVD induction, and in this particular case I used a hard tip suction cannula to lift this IOL and bring it to the anterior chamber. Because view was not very hazy because of compromised cornea, I preferred to do this. After the IOL was lifted onto the anterior chamber, I performed a bimanual handshake technique to explant this lens out. Right when I was doing it, I had to be a little careful because the lens still had those pointed haptic portions which could have damaged the critical structures of the eye. And then we've just followed with our routine plan, went ahead and did a gluteal implantation. My cornea colleagues always insist to give them a good round pupil and good pupillary support before they attempt endothelial keratoplasty so that they can inflate the bubble and support the graft well. So after this, I was rather forced to do a pupilloplasty and managed it decently well. And then the case was handed over to my cornea colleague who did a beautiful desmentorexis, injected a endothelial graft derived from a relatively younger donor, unfolded it, centered it, and inflated the air bubble. Yeah, we're done. And just patched it up with the glue. I'll just show you the first day post-op outcome, which was very good both clinically as well as on...
Wonderful, Dr. Lamba, for such a complicated surgery now. You see now the difference, the real teaching pose when you face a complicated situation. That's the difference now. This is no Bollywood heroic. This is the real on-the-field work, hard work.
Dr. Gaurav Luthra.
Let me take you back a few years. Since this was about 5-6 years back, I was operating and there was a very hard cataract with a small rhexis. Just see, as I stretched the thing, I noticed a broken rhexis, and this is how we managed it. And if you'll notice, there was a small break in the posterior capsule here. We tried to proceed with that, thought I would be able to finish the surgery, and landed with a dropped nucleus, which we removed subsequently. Now come to 2015. Now this is how I would manage such a case. I'm chopping this hard cataract, and I have a better size rhexis now. Your chamber is well formed before you switch off the infusion and come out, and then rotate the nucleus a bit to the side. So we've have this option of now moving the nucleus out of the way over the iris plane on the side, and then once that is done, I can go with the vitrectomy and inject a lens. So now here I'm injecting a lens which is going to give me the space to remove this nucleus. Now I will position this leading haptic into the sulcus, inject some viscoelastic. We have all the fragments above the lens. So you saw what happened 5 years back when my nucleus piece dropped, but now I'm well prepared thanks to Dr. Amar's new technique, and I think all of us can use it. I wanted to give you this message that this technique is very easy, and we can all follow it up, put this in the sulcus, and then you can just go and remove this nucleus. Of course, the vitrectomy is very, very important so that there is no vitreous here, and you can use triamcinolone to actually clear off any small vitreous strands, so you don't want to aspirate them in your phaco-port. And once you have all the nucleus out of the way, you can then go and remove some of that cortex. Now it's a little tricky to remove the cortex because you have to sometimes go behind the lens, but remember that because your other haptic is still above the iris, there is enough space. You can go from the side port and use bimanual IA, remove all the small cortical fibers, and then go clear if there's any vitreous remaining there, and then position the lens. If it's possible, if it's a small break, you could actually go with a single piece lens into the bag. Otherwise you would have to put a multi-piece lens in the sulcus. Here we were able to clear off all the vitreous and then pull out the haptic and then let it go into the bag, as you'll just see here. I'll try to just take you to the end of this video. Here I'm putting the second haptic into the bag, and once we are done, it gives me a great situation, and we've managed this case very well. Thank you. I'll finish and hand over to Dr. Vasavada.
And last but not least, Abe Vasavada, we're going to respectfully ask for another 30 seconds because of my video problems.
Well, now the real teaching is being hammered once again before you go, because you saw a guy from San Francisco, the value of pars plana vitrectomy, and this is a 46-year-old lady with demarcated posterior subcapsular cataract, and we all thought it's not a posterior polar cataract, and we did what we normally do, and we prefer a femtosecond delineation, but in a posterior polar, we thought it's not a posterior polar, so we conventionally did the chopping technique, but fortunately we were okay, and we could manage that capsule intact, and then we removed this epinucleus, and you can see that that's going well. So that is, we succeeded in preventing the posterior capsular rupture in spite of that demarcated capsule, and this is where the things not quite right. The lens actually is tilted, and that thing, we were concerned, this being a posterior polar, query posterior polar cataract. Now we are thinking this could be posterior polar cataract, and you can recognize this little dent. We thought it's okay. And we continued with bimanual IA, and you can see that in a short time, without any mechanical touch, you can see that posterior capsule rupture. So we wonder what happened, but it doesn't matter what was the reason. Now we need to act. And that's where we come into this situation. And this is very typical of me. I have been stressed so many times, and my assistant really is so handy for me to kind of situation like that. So now I go back again. Imagine this is not my case. This is the Bombay or Chennai cases. How do I help them? So I go back, seal the incision before I withdraw, and then I have to use and make sure there is no vitreous. But to my dismay, I found that there is a blob of vitreous coming to the main incision. So triamcinolone is something, in case of doubt, we need to inject and make sure you're not wishfully thinking that there is no vitreous. And that's what is happening now. I injected the viscode, and then once again, what David showed, how valuable it is to perform pars plana, and it's not difficult at all. You go 2.5 or at the most 3 millimeter away, either with the trocar or with the conjunctival lance knife as you saw, and see how beautifully the vitreous in the anterior segment is being drained into that vitreous. And you saw that in a very first film, and it's so important that I want to repeat that, because this is the only thing you today go back home, and this is the message today of this OPL session. Perform pars plana vitrectomy, whether you're doing glued IOL or scleral or whatever those heroics you saw. None of them did a pars plana vitrectomy as the Frisco guys showed it today. So that's what is the thing you want to take it home. And now this blob is stuck, caught in the anterior into the incision. So you need to address it with the anterior approach, limbal approach, and then you just inject and do more vitrectomy there. I'm not able to handle this. Right. And then at the end, you seal the incision, and this is how it would look at the end of the table, and this is how it looked the next day. And 7 days later, it's so stable. The restore sitting well centered. I don't get this such centration with intact capsule many times. So this is the beauty. And what helped me, and you must remember this is the thing. Pars plana vitrectomy and not limbal vitrectomies, and see the beautiful IOL down the line 2 months later. This is the what Pauls we want to share, pars plana vitrectomy. Ladies and gentlemen, thank you so very much.